Hello, everyone, and good afternoon. My name is Carl, and together with me is Sean. And today we're going to be talking about drugs for allergies, or our antihistamines. But before we go into further detail about our drugs, let's first have a short discussion on histamines and what it does. So, histamine is a small molecule produced by our bodies through the decarboxylation of amino acid histidine. So, it is widely distributed sa atong mga tissues, but particularly concentrated siya sa tuang skin, sa atong lungs, and our gastrointestinal tract. Most of our histamine is generated and stored within granules in the mast cells. Kaning mast cells, kay mo sila ang mga type of white blood cells that is found in the connective tissues all throughout our body, especially under the skin. Basophils, a least common type of granulocyte representing only about 0.5 to 1% of circulating white blood cells. Eosinophils, another type of WBC responsible for combating multicellular parasites and certain infections. And lastly, enterochromaffin-like cells, which are located in the stomach lining. Now, there are actually three major conditions that trigger the release of histamine, and the first one is our allergic reactions. So, when an allergy prone individual for the first time comes into contact with allergen, such as a ragweed pollen, ilang mga B cells will become activated and will form plasma cells that produce large amounts of ragweed immunoglobulin E antibodies. These antibodies are abbreviated as IgE. And then these IgE firmly attach themselves to the mast cells, and now, when that same person, comes into contact with that ragweed pollen again, the binding of the allergen to the IgE antibodies will trigger the activation of the mast cells, which will then release granules rich in histamine. And here we have another condition that triggers histamine release, and that is our tissue injury. So when tissue injury occurs, the damaged mast cells release chemical mediators, and among them is histamine, which affects the blood vessels and nerves in the damaged area. Finally, the third major stimulus which triggers histamine release can come from drugs and foreign chemicals or compounds found in venoms, antibiotic bases, dyes, and alkaloids such as morphine. So these are a few examples that can directly displace histamine from the granule stores. Now, what does histamine do following its release? Well, histamine exerts its effects by binding to the various types of histamine receptors found mainly on the different cells throughout the body. And to date, there are actually four types of histamine receptors na atong na-identify, and that is our H1, H2, and H3 receptors. However, in this lecture, we're only going to focus on the first two types of receptors because they are the main targets of our clinically useful drugs. So the first type, H1 receptors, are expressed primarily on the vascular endothelial cells, the smooth muscle cells, as well as in the brain and on the peripheral nerve endings. These receptors mediate mainly inflammatory and allergic reactions. So when histamine binds to the vascular endothelial receptors, it causes blood vessels to dilate and thus making them more permeable, ultimately leading to redness and edema. Now, when histamine binds to the smooth muscle receptors, particularly the ones located on the bronchioles, it causes bronchoconstriction. Histamine also acts as a neurotransmitter within the central nervous system. So, histamine binding to the H1 receptors in the brain prompts other things like wakefulness and appetite suppression. And lastly, histamine-mediated stimulation of the peripheral nerve endings leads to pain and itching sensations. So for histamine type 2 receptors, these receptors are expressed mainly on the gastric parietal cells. So when histamine binds to the H2 receptors located in the acid-secreting gastric parietal cells, this initiates cascade that eventually increases the intracellular cyclic adenosine monophosphate or CAMP. Cyclic CAMP activates the hydrogen potassium pump, causing secretion of hydrogen ions. Now, in order for us to further understand the effects of histamine, I have attached a short video about this.
Through the H1 receptor, histamine dilates blood vessels and constricts the cells lining these vessel walls, causing increased blood flow to an affected area and allowing immune cells from the blood to escape the vessels and enter inflamed tissues. This can lead to the swelling and sensation of warmth in tissues, the presence of hives in the skin, and can also cause fluid to be expelled in the sinuses, leading to a runny nose, teary eyes, and sneezing. Histamine can also act locally on nerve terminals, causing an itching or painful sensation. Airways constrict in response to histamine, and the contractile force of the heart can be increased as well. Most importantly, histamine release initiates an immune response where other immune cells are recruited, additional pro inflammatory molecules are released, and inflammation is exacerbated. Antihistamines help prevent this cascade from occurring.
So thank you guys for watching the video. Now let's switch gears and talk about the drugs that block the action of histamine, starting with H1 receptor blockers. So these H1 receptor blockers are classically referred to as antihistamines. So the H1 receptor blockers can be divided into the older or first generation agents and the newer or second generation agents. These agents act as an inverse agonist, meaning they bind to the H1 receptor on a target tissue and stabilize its inactive conformation. So this leads to the inhibition of histaminic actions and the gradual relief of our allergy-related symptoms, such as our inflammation, our itching, runny nose, and our sneezing. We have to note that H1 receptor blockers are well absorbed after oral administration, with a maximum serum levels occurring at 1 to 2 hours. The average plasma half-life is 4 to 6 hours, except for meclizine and the second generation agents, which is about 12 to 24 hours. And now, on the next slide, let's first talk more about in detail about the first generation H1 blockers. Now, the general structure of the first generation H1 antihistamines consists of two aromatic rings connected to a substituted ethylamine group. And due to this lipophilic structure, the first generation H1 antihistamines can cross the blood-brain barrier and thus cause sedation and potentially impair cognitive function. However, the older first-generation drugs are still widely used because they are effective and inexpensive. Nonetheless, the use of the first-generation antihistamines is contraindicated in the treatment of individuals working in jobs in which wakefulness is critical. Furthermore, they must be used in caution with sedatives and alcohol because sedative effects may be potentiated. Additionally, first-generation agents have relatively poor H1 receptor selectivity, and as a result, they are capable of occupying other receptors such as our cholinergic, alpha-adrenergic, and serotonin receptors. And this leads to a number of side effects. And an example of this would be if we block a blockade of the cholinergic receptors may cause dry mouth, blurred vision, and urinary retention. Blockade of alpha-adrenergic receptors may cause hypotension and reflex tachycardia. And lastly, the blockade of serotonin receptors may cause increased in appetite. However, on the positive side, um, the central histamine and acetylcholine receptors, the blockade of these receptors seem to be responsible for the antiemetic and the anti-nausea effects. Examples of the first generation antihistamines are our um, brompheniramine, chlorpheniramine, clemastine, cyproheptadine, cyclazine, diphenhydramine, dimethylhydrinate, toxylamine, hydroxyzine, meclizine, and promethazine. Although all of these drugs are useful in relieving allergy symptoms, some of them are often used for other therapeutic indications. And an example of this would be our diphenhydramine and our toxylamine, which are often used in the treatment of insomnia, while meclizine and promethazine are more often used in the treatment of nausea and vomiting. related to certain conditions such as motion sickness. So this is just a picture showing the number of side effects of the first generation agents with them having a low H1 receptor selectivity. So another reason why first-generation antihistamines can lead to conditions like dryness in the nasal passage and oral cavity is due to their ability to exert anticholinergic effects. And an example of this later on would be diphenhydramine and its salt, which have significant anticholinergic properties. Patients taking monoamine oxidase inhibitors, for example, phenelzine, should not take antihistamines because these kind of drugs can exacerbate the sedative and the anticholinergic effects of antihistamines. In addition, the first generation antihistamines with anticholinergic antimuscarinic actions may decrease the effectiveness of our cholinesterase inhibitors such as donepezil, rivastigmine, and galantamine in the treatment of Alzheimer's disease. Aside from the most frequently observed adverse reactions, which is sedation in the first generation, diphenhydramine may cause paradoxical hyperactivity in young children. First-gen antihistamines may also cause fatigue, dizziness, lack of coordination, and tremors. And lastly, elderly patients are more sensitive to these effects. So going back to our drugs, traditionally H1 antihistamines have been classified into six chemical groups: alkylamines, ethanolamines, ethylenediamines, phenothiazines, piperazines, and piperidines. But currently, the most commonly used classification system is the functional one, in which H1 antihistamines are classified as either first generation medications that readily cross the blood brain barrier and influence cognitive function, or second gen drugs that cross the BBB only to a limited extent and are relatively non sedating and non impairing. Now let's talk about the important details of some of the drugs of the first generation, starting with cyproheptadine. So strong blocking effects at serotonin receptors have been demonstrated for some of the first generation H1 antagonists, notably cyproheptadine. The major clinical applications of this drug are in the treatment of the smooth muscle manifestations of carcinoid tumor and in cold-induced urticaria. This is an itchy skin reaction to cold that appears within minutes after cold exposure. This drug is of some value in serotonin syndrome, but because it is available only in tablet form, cyproheptadine must be crushed and administered by stomach tubes in unconscious patients. Next, we have the drugs clemastine, diphenhydramine, and chlorpheniramine. These three drugs may cause excitability in children and should be avoided for children below 2 years old. We have to note that diphenhydramine is the most sedating antihistamine, and it also has anticholinergic properties, meaning it can inhibit the transmission of parasympathetic nerve impulses, thereby reducing spasms of smooth muscles. One of diphenhydramine salts, dimenhydrinate, also has significant anticholinergic properties. Diphenhydramine is given parenterally for acute dystonic reactions to antipsychotics, and diphenhydramine is commonly used in conjunction with other antiemetics for the treatment of emesis due to chemotherapy. Next, we have the two drugs meclizine and promethazine. Along with the antimuscarinic agent scopolamine, certain H1 receptor blockers, meclizine and promethazine, are the most effective agents for the prevention of symptoms of motion sickness. They are usually not effective if symptoms are already present and thus should be taken prior to travel. Meclizine has minimal anticholinergic properties unlike diphenhydramine. It also causes less sedation. It is useful for the treatment of vertigo due to labyrinth dysfunction, which is a condition that affects the part of the inner ear that plays a role in the balance of the body. It is also important to note that promethazine and also diphenhydramine are more potent than procaine as local anesthetics and thus may be used as a preoperative sedative. And lastly, these are just the OTC antihistamine sleeping drug aids, namely doxylamine and again diphenhydramine. These drugs are used to reduce difficulty in falling asleep, and they should be avoided in children below 12 years. And an important thing to note is that these drugs should be avoided for men with trouble urinating because they may aggravate symptoms of an enlarged, swollen prostate. So before I end my part, I just want to mention that in cases of significant histamine release leading to anaphylaxis, which is a severe and potentially life-threatening allergic reaction, antihistamine treatment is not sufficient. In such a case, exogenous adrenaline or epinephrine must be used to rapidly counteract the airway constriction and hypotension induced by histamine. So epinephrine is an alpha and beta adrenergic agonist, so it reverses the symptoms of anaphylaxis. So for example, a person's blood pressure plummets during a anaphylactic reaction because the blood vessels relax and dilate, then epinephrine causes the blood vessels to constrict, which raises the blood pressure.
In comparison with the first generation H1 receptor blockers na maka-enter sa blood-brain barrier which results to sedation, a side effect that most antihistamines have in common. Second generation H1 antihistamines does not cross the blood-brain barrier, or at least a minimal extent lang siya since ang chemical structure ng second generation H1 antihistamines is not entirely lipophilic, or some can have a weak potential for producing sedation. That is why we have these less sedating drugs like cetirizine and levocetirizine. Other than that, naabot tayo non-sedating drugs which are loratadine, desloratadine, and fexofenadine, and also the H1 antihistamines with mast cell stabilizing effects such as azelastine, olopatadine, and ketotifen. Overall, si loratadine and fexofenadine are the recommended drugs of choice sa mga tao nga nag-work, especially if their job requires them to be active at all times, even sa gabi, kasi nga they are non-sedating. Nagiging non-sedating siya because second generation H1 antihistamines are more selective to peripheral H1 receptors than H1 receptors found in the central nervous system. These first two second-generation antihistamines, namely cetirizine and levocetirizine, belong to the less sedating group. While cetirizine is a carboxylic metabolite of hydroxyzine, levocetirizine is the eutomer or the R enantiomer of cetirizine, having the desired pharmacological activity. The distomer, on the other hand, is the S enantiomer of which may have undesired bioactivity or may be bioinert. Although pinakabago lang gi-introduce na antihistamine si levocetirizine, and it has significantly improved nasal congestion, nasal itching, sneezing, eye itching, and eye redness. When comparing both medicines, cetirizine improved most symptoms better than levocetirizine, especially nasal congestion. And these drugs are used for seasonal or short-term allergic rhinitis, perennial or long-term allergic rhinitis, and chronic urticaria. Kaning urticaria, it is characterized by wheals or the raised and red swollen marks sa skin na makita ninyo sa picture, and it is usually accompanied by itching. Their adverse effects include somnolence or drowsiness, also fatigue, dry mouth, pharyngitis, and dizziness. So, dili na sabta sa mga non-sedating antihistamines. Desloratadine is the active form of the drug loratadine. In this case, that means loratadine doesn't exert too much of an effect until it is in its active form. The objective was to create a new drug that had the same wanted effect, which is to reduce allergy symptoms but without or lesser side effects like sedation. Loratadine is effective enough itself, but desloratadine works better kasi nga it has fewer side effects. The theoretical consequence of this is that the drug should achieve a stable concentration in your body faster. Whereas, if you were to take desloratadine, it should be a quicker start. On the flip side of that, concentration goes down quicker as well. In other words, it lasts for a shorter duration only. Mas mataas pa rin yung potency ni desloratadine than loratadine even if it doesn't last long kaya nagagamit siya at lower doses. The key difference between loratadine and desloratadine is the absence of an ethyl carbamate type moiety in desloratadine. So, na-learn nato sa previous antihistamines that the second generation H1 receptor blockers were developed to reduce adverse effects while retaining efficacy. The third non-sedating antihistamine naman is the fexofenadine. Fexofenadine is a highly selective second generation antihistamine, effectively alleviates symptoms of allergic rhinitis and chronic idiopathic urticaria. Lipophilicity and ionization at physiologic pH are important determinants at brain penetration. Fexofenadine is ionized at physiologic pH and crosses the blood-brain barrier to only a minimal extent. In other words, it is still devoid of cardiovascular side effects. Overall, fexofenadine displays a favorable safety profile and results in greater treatment satisfaction in children compared with other second-generation antihistamines. Fexofenadine do not work in suppressing cough. The ineffectiveness of fexofenadine in suppressing cough probably reflects the lack of anticholinergic activity and central nervous system penetrance that is a characteristic of the first-generation antihistamines. It is also advised not to drink grapefruit juice, apple juice, or orange juice while you are taking this medication because it can lead to decreased blood levels of fexofenadine, meaning your antihistamine may not work as well. Next classification of second-generation H1 antihistamines are those with mast cell stabilizing effects such as azelastine. Azelastine is a combination of histamine blocker and a corticosteroid. Unlike most oral antihistamines, azelastine nasal spray is much more effective in alleviating nasal congestion. A nasal corticosteroid spray reduces swelling and mucus in the nasal passageway. It is well tolerated in both adults and children with allergic rhinitis. Azelastine is indicated to seasonal rhinitis, perennial rhinitis, and vasomotor rhinitis. Adverse effects may include drowsiness, bitter taste in mouth, cold symptoms, fever, vomiting, nose itching, throat pain, or nasal pain. And azelastine should not be used more than 4 sprays in each nostril per day, and its use is not recommended for children younger than 6 years of age. The next antihistamine with mast cell stabilizing effects is olopatadine. It works by preventing the release of substances that can cause eye itching. Itchy eyes are the result of histamine release caused by allergen-induced degranulation of mast cells. The mechanism of action of mast cell stabilizers is inhibiting the degranulation of mast cells. When these mast cells are prevented from its activation, it also inhibits the secretion of pro-inflammatory cytokine from human conjunctival epithelial cells. These cytokines are responsible for the production of interleukins 4 and 13, which promotes immunoglobulin E production, and tumor necrosis factor alpha, which promotes tissue inflammation. These are the factors causing eye itching in using antihistamines without mast cell stabilizing effects. So the desire to rub one's eyes, however, can also be a response to dryness, as rubbing can increase reflex tearing and meibomian gland secretion, helping to temporarily relieve ocular discomfort. Olopatadine is indicated for allergic conjunctivitis, also known as pink eye. It is available in ophthalmic drops, so it should never be shared between patients, and it is best to remove contact lenses if you have one before application because olopatadine contains benzalkonium, which can discolor soft contact lenses. Thus, it can also lead to eye irritation. Ketotifen is also a non-competitive histamine antagonist and a mast cell stabilizer. Administered orally, it functions as a non-bronchodilator anti-asthmatic drug by inhibiting the effects of endogenous substances known to be inflammatory mediators. It is indicated for the treatment of mild atopic asthma and allergic conjunctivitis, but it doesn't have an effect in preventing or treating acute asthma attacks, and it only works by inhibiting certain substances in the body that are known to cause inflammation and symptoms of asthma. The presence of other medical problems may affect the use of this medicine, so make sure you tell your doctor that if you have any medical problems, especially diabetes, as it may alter low sugar diet. This is because ketotifen syrup contains carbohydrates. Also epilepsy, as it may increase the risk of convulsions or seizures. So makita niyo sa picture no unsa ang difference sa allergic conjunctivitis compared sa bacterial and viral conjunctivitis. While allergic conjunctivitis may share some of its characterization to one or two types, it is the only one nga nagaproduce of itching. That is why the use of mast cell stabilizers such as ketotifen, olopatadine, and azelastine is very important. Next are H2 receptor blockers. So to understand how this drug works, first we need to take a closer look at their primary target, that is acid-producing parietal cells of the stomach. So parietal cells has three types of receptors which control acid production, that is the acetylcholine receptor, gastrin receptor, and histamine H2 type receptor. Now, parasympathetic vagus nerve that innervates the GI tract releases acetylcholine, which acts on acetylcholine receptor to increase intracellular calcium. Next, gastrin, which is a hormone produced by G cells located in the pyloric glands, acts on gastrin receptor to also increase intracellular calcium. Additionally, gastrin stimulates nearby enterochromaffin-like cells to synthesize and secrete histamine. Finally, the histamine secreted from enterochromaffin-like cells acts on the H2 receptor to activate adenylyl cyclase, leading to increase of intracellular cyclic AMP levels. Now, this increase in intracellular CAMP and calcium results in activation of protein kinases, which in turn stimulate hydrogen potassium ATPase, the so-called gastric proton pump, or the final common pathway for acid secretion in gastric parietal cells. Overall, H2 antihistamines are medicines that reduce the amount of acid produced by the cells in the lining of the stomach. It is indicated in peptic ulcer disease, gastroesophageal reflux disease, and diseases associated with gastric ulcers such as the Zollinger-Ellison syndrome. So the Zollinger-Ellison syndrome is a rare endocrine syndrome with three interrelated pathologies. First is gastrinoma, then increased gastric acid secretion, and peptic ulcers. H2 antihistamines doesn't much have side effects, and they are generally safe except for cimetidine because it has anti-androgenic effects which can cause gynecomastia and also hirsutism. Gynecomastia is a common condition that causes male breasts to swell and become larger than normal. It is most common in teenage boys and older men. Hirsutism, on the other hand, is a condition in women that results in the excessive growth of dark or coarse hair in a male-like pattern sa face, chest, or sa likod mismo. So, mauna siya ang mga H2 antihistamines. Cimetidine or the prototype H2 antihistamine, famotidine, the most potent among H2 antihistamines, nizatidine, the most bioavailable one, and also ranitidine. These are all for the pathophysiology of allergic responses, antihistamine medications, and its classification. Thank you for listening.